A very warm welcome to everyone who is watching us right now on the YouTube channel. I'm Dr. Kaushika. Today, I have the pleasure of introducing you Professor Chamara Dalugama, consultant physician and a professor in medicine in University of Peradeniya. I'm sure he's gonna be sharing all of his expertise with you today, and all of us will be learning something new at the end of this session. So, before we get started, why don't you all think on how to tackle a patient with abnormal lipid levels coming to your consultation? Well, we are going to have a patient-based discussion on this topic. So, first of all, let me introduce our patient. She is Mrs. Pereira, a 45-year-old preschool teacher, presents to her GP for a body checkup, stating that her brother recently suffered a stroke. She wants to know whether she's got any risk factors for such vascular event. So, in the first place, I would like to know whether a lipid profile is indicated in this patient.
Yes, Kaushika. I think you all will agree that this is one of the commonest patients that we encounter in our clinical practice. So, in this particular patient, of course, a lipid profile is indicated. And as per recommendation, anyone more than 20 years of age, a lipid profile is indicated as a screening test. Mrs. Pereira, she is 45 years of age, and also she has a very significant atherosclerotic vascular risk of family history. Therefore, we have to do a lipid profile as a screening test.
Okay, as you clearly stated, it is indicated. Could you please explain how to advise a patient on doing a lipid profile?
Right. So, general recommendation is that patient needs to be overnight fasting, that is 10 to 12 hours of fasting before withdrawing blood for a lipid profile. But interestingly, there is recommendations coming from UK and US in newer guidelines that non-fasting lipid profiles are also equally efficacious and equally important as fasting lipid profiles. Because the argument is that a non-fasting lipid profile is more convenient for the patient as well as for the physician, and at the same time, in physiological states, we are most of the time at a non-fasting state. So in that case, it will be more physiological than doing a fasting lipid profile. And also, only lipid parameter which changes in a fasting state is the triglyceride levels. And most of our recommendations are based on LDL cholesterol, which is not commonly affected by the fasting state. So, we can go for non-fasting cholesterol levels as well.
We'll assume that Mrs. Pereira comes with a lipid profile. How are we going to interpret the lipid profile correctly?
Right. Of course, Kaushika, that is a very difficult question. Because if you give me a fasting blood sugar or an HbA1c, it is very easy for me to diagnose diabetes. But in lipid profiles, you have to think always from the individual patient's context. Because one LDL level, which is very normal for a person, can be dangerously abnormal for another patient. So in that case, we need to think about the cardiovascular disease risk of the patient, as well as we need to think about the treatment targets and treatment goals for that particular patient.
The next question that pops in our mind is whether she's got any risk factors for a cardiovascular event. How would you assess the cardiovascular risk of a patient?
Right. So before I answer your question, let me tell what is meant by a cardiovascular disease risk assessment. So basically what it means is, in very simple terms, that is the risk of or the likelihood of patient getting atherosclerotic cardiovascular disease. That can be a myocardial infarction or that can be a stroke within a defined period of time. So usually most of the time we talk about 10-year atherosclerotic cardiovascular disease risk. So for that, of course, we have a lot of ways and means of calculating this. The simplest thing would be to go for a WHO risk assessment chart. So as in the slide that I am showing you, when you are assessing the cardiovascular disease risk, you have to select the area specific chart. So Sri Lanka, we take the Southeast Asia or Southeast Asia region as the chart. And then the next thing is you need to think whether you have laboratory facilities to make a diagnosis of diabetes in this patient or not. So if you know whether the patient is a diabetic or not, you can take the laboratory based charts, and if you don't know the diabetic status, we have to go for the non-diabetic charts. And then we have to think about whether this patient is a smoker or not. And then we have to think whether this is a male or a female patient. So depending on all these parameters, we have to select the appropriate box. So in that box, we have to go for that particular age category, and then we have to know what is the systolic blood pressure and what is the total cholesterol. So in that case, the color of that specific box where the systolic blood pressure crosses the total cholesterol level, the color gives the 10-year atherosclerotic cardiovascular disease risk. So it can be less than 5%, 5 to 10%, 10 to 20%. Likewise, we can get a risk assessment.
Let's assume our patient is a non-smoker with a systolic blood pressure of 165 and a HbA1c of 7% with a lipid profile having total cholesterol level of 295 and a LDL cholesterol level of 182. How high is the risk for a cardiovascular event?
Right. So if you put the same algorithm into what we have just discussed, so now you can see in the slide that we have selected the appropriate area specific chart, and she is a non-smoker, female, and then we have selected her age category, and her systolic blood pressure is 160 and her total cholesterol is 7.2 millimoles per liter if you convert it to millimoles per liter. So she falls into the risk category that I have depicted here. So she is at 10 to 20% risk of developing a stroke or a myocardial infarction in 10 years time.
As you clearly explained, sir, now we all know how to assess the cardiovascular risk of a patient, and our next goal is to target the treatment. What are the treatment targets and treatment goals in lipid-lowering therapy?
Right, okay. To answer that question, first I will have to talk about treatment targets. So we have two types of treatment targets. One is the primary prophylaxis and the other one is a secondary prophylaxis. So the primary prophylaxis is that, like this patient, Mrs. Pereira, who did not have any atherosclerotic cardiovascular disease risk or cardiovascular diseases in the past. So she doesn't have a history of MI or stroke or peripheral vascular disease. So what she needs is the primary prophylaxis, right? But if you take another patient who had a previous history of stroke, like say Mrs. Pereira's brother who had a stroke, so what he needs is secondary prophylaxis. So that is how we divide the primary prophylaxis and the secondary prophylaxis.
Well, I have heard that the lifestyle modifications play a major role in lipid-lowering therapy. Would you please elaborate on how to advise a patient regarding lifestyle modifications?
Right. Okay, Kaushi, so that is a very important question. So we have the targets as well as goals. So when I'm talking about the targets, there are two targets. We have the primary prophylaxis and we have the secondary prophylaxis. So what is meant by primary prophylaxis is simply that somebody like Mrs. Pereira, who does not have any vascular risk factors, come in with elevated cholesterol. So she doesn't have history of myocardial infarction, nor history of stroke or peripheral vascular disease. So that is primary prophylaxis. But then in contrast, if you take Mrs. Pereira's brother, whom she is worried of, he had a major vascular event, he had a stroke. So for that particular patient, we are going for secondary prophylaxis. And then the treatment goals are different under each category. So if we take primary prophylaxis, the next thing we would do is to calculate the 10-year atherosclerotic cardiovascular disease risk. So if the cardiovascular disease risk is high, or we say more than 20%, the LDL target would be to reduce it to less than 70 milligrams per deciliter. But patients who are having moderate risk, where the risk is between 10 to 20%, the LDL target is to bring it to less than 100 milligrams per deciliter. And the patients who fall into the low risk category, where the LDL target is less than 116. So even in primary prophylaxis, we will have different treatment goals according to their cardiovascular disease risk. But in contrast, if you are going for a secondary prophylaxis, if they had a major vascular event, we target an LDL cholesterol to less than 55 milligrams per deciliter. And if this patient is having recurrent vascular events despite having low cholesterols, then we have to lower our target to 40 milligrams per deciliter. So that is what is meant by treatment targets and treatment goals.
Well, I have heard that the lifestyle modifications per se play a major role in lipid-lowering therapy. Would you please elaborate on how to advise a patient regarding lifestyle modifications?
Yes, Kaushik, I think that is a very important question because that is the mainstay in when we are treating high lipid levels, right? So when it comes to lifestyle, I think diet plays a major role. So we always advise the patient to reduce the saturated fat in their diet. So if I have to give some examples, your coconut oil and then ghee and all these things will have a lot of saturated fat. But in contrast, the olive oil, the canola oil, sunflower oil, these oils are coming from the non-tropical sources, have more unsaturated fat, which is good in lipid lowering. And also we recommend to go for red rice or brown rice instead of refined rice. And also importantly, we advise the patient to cut down on their sweets and starches.
There's another question that I would like to point out here, sir. As Sri Lankans, we use coconut oil in our day-to-day diet. So, we all are keen to know about the use of coconut oil in the diet. What advice can you give on that?
So, I think that's a very important question because as Asians, we do consume a lot of coconut oil. So, when we talk about the effect of coconut oil on lipids, it increases your HDL cholesterol as well as the triglycerides and the total cholesterol. Also, although there is a beneficial effect on the LDL cholesterol, it increases the LDL as well as total cholesterol. So, if you take the total, it has a negative cardiometabolic effect. So, therefore, it is best that if you have abnormal lipids to cut down on coconut oil. And instead of coconut oil, we can move for more non-tropical oils such as canola oil, sunflower oil or corn oil.
Well, coming back to the case scenario, what is the first line treatment for our patient, provided that her total cholesterol level is 295 and LDL level is 182?
Right. So, the first line treatment, if we talk about the pharmacological aspect, it is the statins. So, statins, we have different types of statins available in Sri Lanka. We have simvastatin, atorvastatin and rosuvastatin. So, here we go by the intensity of the statin. So, what's simply meant by intensity is that the percentage of lipid lowering. So, we have to take the individual patient and see what is his LDL cholesterol and what is his treatment target and the treatment goal. So, if we want to reduce his LDL by more than 50%, we will have to go for a high intensity statin. So, for example, high intensity statin is 40 milligrams of atorvastatin and 20 milligrams of rosuvastatin.
As you clearly mentioned about the treatment options, there would be problems if the treatment target is not achieved. In such cases, how to intervene in order to achieve the treatment target?
Right. So, that is very important because we always, when we manage abnormal lipids, we should have a treatment target. And we have to monitor the patient to see whether the target is being achieved. If it is not the case, say for instance, patient is on a moderate intensity statin, we can increase it into a high intensity statins. But sometimes what we commonly find is patients are on high intensity statins, but their treatment targets are not achieved. So in that case, we will have to consider other options such as cholesterol absorption inhibitors or bile acid sequestrants. So the cholesterol absorption inhibitor what we have here is ezetimibe, and then the bile acid sequestrants are cholestyramine. So if the LDL targets are not achieved, we can consider starting the patient on ezetimibe or else starting on cholestyramine.
Coming on to a different set of questions, sir, regarding statins. We do have many concerns as doctors when we prescribe statins to our patients. One thing some of us are concerned is whether to do a CPK level before starting statins. What do you think about that, sir?
Right, so that is a common practice because some doctors tend to do CPK levels before starting statins. But the general recommendation is that is not required. So if your patient is completely asymptomatic, there is no indication to do a CPK level before starting your cholesterol therapy. But when the patient is started on statins, and if the patient complains of muscle symptoms, that is the place where we need to think that whether there is some muscle inflammation or myositis, and then you can do a CPK level.
In some of our patients, liver transaminases are already high. In such cases, how to proceed with statin therapy?
Yes, I think that's a very important question because mild elevations of transaminases, SGPT and SGOT, are not uncommon because most of the patients who are having abnormal lipids, there are a lot of other conditions that can coexist. Say for instance, patient can be having fatty liver or non-alcoholic steatohepatitis, or else patient may be ethanol consumer, so there can be ethanol related transaminitis. So in such cases, we should not abruptly stop the statin therapy because statin therapy is important and it can be life-saving at times. And if the transaminases are high, we can carefully monitor the liver enzymes and we can continue statin therapy. But what is clinically significant transaminitis is that the transaminases, the SGPT and SGOT levels are more than the 3 times. So in such cases, we can hold the statin for a while and then we can restart it at a lower dose.
I've got another point to clarify regarding statin therapy, sir. I have read that the statin therapy increases the risk of new onset diabetes mellitus. Is that significant?
Well, it is a dose dependent effect. So depending on the statin dose, it is noted that there can be some increase in blood sugar levels. But if we weigh the benefits and risks of statin therapy and having diabetes, the benefits far outweigh the risks. So in that case, because of this theoretical risk of having diabetes, we should never stop the statin therapy. I think that is the answer.
Well, there are many patients who are concerned on adverse effects of the drugs that we prescribe. Will statins have adverse effects specifically on renal functions of our patients?
Well, I have a very clear answer for that. The answer is no. And commonly we see, particularly in patients who are on secondary prophylaxis, they are on 40 to 80 milligrams of atorvastatin, and after some time when they come, we see that they have cut down their statins on their own. So they take just 10 milligrams or 20 milligrams. And if we ask what's the reason, they will tell, I'm scared because I'm on a lot of treatment, I'm on a lot of tablets and that will interfere my kidney functions. I think that is a common misbelief and we should always tell the patient that statins will not have any effect on their kidney functions.
If we come back to our patient, I would like to know how often should I repeat the lipid profile in our patient?
Right, so in Mrs. Pereira, now this is the first time we are starting her on a statin. So we have to go for a goal-directed therapy. So depending on her cardiovascular risk, we have an LDL goal. Until that we can achieve that goal, we have to repeat the lipid profiles in every 3 to 6 weeks time, and once the goal is achieved, that we can monitor the patient subsequently.
Well, I would like to point out another key issue in our patients, which is not tolerating the drugs that we prescribe. What to do if the patient is not tolerating statins?
Right, I think that is again a common problem that as doctors we encounter. Patients will have lot of symptoms when they are started on statins. So there are a lot of options that we can go for. One thing is sometimes these symptoms can be a class effect. So one class of statins like atorvastatin might cause lot of symptoms, but patient may tolerate rosuvastatin well. So we can switch the class to a different class. And the second thing we can do is we can stop the statin for a while and then we can re-challenge. Or else we can reduce the statin dose. Or else in some patients we have seen that taking statins in every other day helps to sort of reduce their symptoms. So all these things that we can try on these patients.
Actually, we've already got a detailed explanation regarding statin therapy. I would like to know one more thing about statins. If we take patients as a group, Some of the patients are fallen into special categories like pregnant women and lactating mothers. In such patients, can I use statins?
Well, I think that is again important because nowadays we do see a lot of patients, young patients, having abnormal lipids, and we do start them on statins. But as a general recommendation, statins are not recommended during pregnancy or in lactations. And our general advice is to stop the statin at least 3 months before conception. But the thing is, there are certain patients where they are at high risk of atherosclerotic cardiovascular disease risk. Particularly, there are patients who have established cardiovascular disease. Say, for instance, there can be a young female who had a stroke or a young female who had a myocardial infarction. So, in such cases, I think it is best that we decide on the statin with a multidisciplinary team involvement. The physician, the endocrinologist, the cardiologist, we all get together and we have to carefully weigh the risks and benefits of statins and to decide to continue statins in such categories. But in general, in pregnancy and lactation, statins are not recommended.
2 more questions left for you, sir. As we all know, the patients are having multiple diseases at the same time. One of the most common diseases that the patients are suffering is hypothyroidism. Is there any association between hypothyroidism and high lipid levels?
Yes, there is a very significant association between hypothyroidism and abnormal lipid levels. So, if there is a patient who is hypothyroid, he is at increased risk of having high LDL and high triglyceride levels. So, sometimes in such patients, if you treat the hypothyroidism, the lipid abnormalities will get automatically corrected. Therefore, as a take-home message, every patient who comes with an abnormal lipid profile, we should go for a thyroid assessment by doing a TSH, and then if the patient is hypothyroid, we can start treating them for that with thyroxine. And importantly, in patients who have abnormal lipids with undiagnosed hypothyroidism, if we start statins, they are at increased risk of developing severe muscle symptoms and rhabdomyolysis. So, as a general rule, any patient with abnormal lipids, you have to do a TSH.
One last question, sir. In some patients, we see isolated very high triglyceride levels. How do we manage such cases?
Right, I think that is again a common finding that we see, very high triglyceride levels. So, by definition, if your triglyceride level is between say 180 to 500 milligrams per deciliter, we call it moderate hypertriglyceridemia. And if your triglyceride levels are more than 500, that is severe hypertriglyceridemia. High triglyceride levels can be a vascular risk factor, but when the triglyceride levels are very high, that can increase the risk of pancreatitis. So, when it comes to moderate hypertriglyceridemia, the mainstay of management is to look for secondary causes. So, diabetes, metabolic syndrome, hypothyroidism, they are very common causes which can give rise to high triglyceride levels. And also drugs like steroids and certain hormone therapies like tamoxifen can increase triglyceride levels. So, it is not always recommended to start a statin or a fibrate in this moderate category. What we can do is we hunt for a secondary cause, we treat that cause, and the triglyceride levels will automatically come down. But when it comes to the severe triglyceridemia group, where they are at increased risk of having pancreatitis, we tend to start them on treatment. Again, the first line recommended treatment is to start them on a statin. And then we can recommend them to have a very low fat diet and a very low sugar diet. And this category will benefit with fish oils as well. With all these measures, having statins, low sugars, low fat and fish oil, if their triglyceride levels are persistently elevated, we can add a fibrate. But adding a statin and a fibrate just to control LDL levels are not recommended. So, it is mainly in very selected patients where we consider adding a fibrate as an add-on therapy to the statin, because the combination of a statin and a fibrate would increase the risk of rhabdomyolysis greatly.
Well, that brings to the end of our discussion today. We had a very, very informative and an excellent session with you, sir. All of us got benefited from your breadth of knowledge and depth of expertise. Thank you very much, sir.
Thank you, Kaushi.
Have a great day.